Okay, thank you. So let's proceed to the last presentation of this session. So here I will present the airways, the comparison in the patient with the UCLP, BCLP, and the normal class 3 malocclusion patients. First of all, I have to always emphasize on cleft is the most common craniofacial deformity in our daily practice. However, children with the cleft, they in the literature reviews or in other center, for example, in our center, they in average should receive 4 to 6 stage reconstructive surgery in the growing stage. And corrections of all the deformity, including how to deal with the restriction of the maxillofacial deficiency, and then is the malocclusions, the getting worse, and how to deal with the speech deformity, and what is the swallowing difficulty too. There are always is the concern not only from the patient, also will be feedback from their parents. However, after serial the surgery or over the focus on the mid-face, lots of scar will occur, and all of the scar accumulate, and later on will limit the development of the mid-face as well. That probably will induce all the patient with your performance has a concave facial profile, and leading they should receive the jaw surgery to correct the malocclusion and the facial profile. And as we know, prognosis is always the very standard presentation for most of the patient with the cleft. And after maturity, we have to identify what is the right indication to persuade all the patient to receive combined orthodontic and orthodontic treatment in the same time. In our data, approximately around 37.5% of the patient with the cleft who needed the further orthodontic surgery in our center. And the main purpose to receive OGS is to correct and to have a better oral function, facial profile, and have a nice psychosocial health in the daily life. However, as we know, the pharyngeal flap is a very leading factor to induce the velopharyngeal to treat the velopharyngeal insufficiency. But the limited of the airway space will make all the patient to complain the snoring or the sleep disturbance. We have to highly to collect all the patient in our group to know is any the confounding factor or the comorbidity to happen to make the patient to have a side effect, including the obstructive sleep apnea after the patient receive the OGS. Yesterday, I remember one of the questions from the audience. They asking, how is the patient with the cleft receiving pharyngeal flap, and do they have the OSA afterward? Yesterday, probably I misunderstanding of the questions, and I go back to check our previous data from Professor Liao in 2002 and 2004 in CPCJ. At that time, 20 years ago, the patient received a pharyngeal flap or the furlough flap to correct the primary cleft parodonticity, and they received the PNG, the sleep study, to evaluate the possibility of the sleeping disorder. Surely, furlough group and the pharyngeal flap group, they really to reveal a no good sleeping quality afterward. And the pharyngeal group, they have more severe the OSA problem afterward. However, in my study, in this scenario, it's the different type. I just want to know what is the airway be evaluated before and after the OGS, and I circulate those group with the pharyngeal flap patient to know under no division of the pharyngeal flap, what is the airway change. We're using three-dimensional combined CT to evaluate preoperative and postoperative 1 year after to calculate the air weight. And the group we divided into the UCLP, BCLP, and within the UCLP, we divided into the patient received a pharyngeal flap or not. And the timing we divided into the two time T0 and the T1. 0 means the before, T1 means at least 6 months after the surgery. This is the standard protocol, the tripart surgery to be delivered in our center. They consist of the two-jaw surgery. And always before the surgery, we do a simulation to know what is the right reposition of the maxillary and the mandibular complex afterward, and to show a nice favorable result. And this is our simulation before the surgery using the software to identify what is the right position of the MMC based on the rotation and the translation movement. So we're using the combined CT to segment it. Before the surgery means the T0 is in A, and the T1 is post-operative 1 year. And we could do the superimposition to know before and after what is the translational movement for the point A and the point B, to know after the OGS what is the AB movement in those cases with the cleft. Besides, we have to identify what is the pharyngeal airway. We divide it into the 3 parts. So upper part, middle part, and the lower part. Upper part means the velopharyngeal airway. This is borderlines in between the posterior nasal spine, PNS, to the uvula. The middle part is the oropharynx, and be bordered by the uvula to the epiglottis. And the lower part means the hypopharyngeal, is below the epiglottis and above the vocal cord. So this is segmented in our software from our combined CT. You can easily to know the figure A and the B and the C. They are all be segmented based on our definition of the 3 different airway here. So in the first comparison of the UCLP and the BCLP, and within the UCLP with and without the pharyngeal flap. In the group of the UCLP and BCLP, we have the similar case numbers, and all the patients receive orthodontic surgery is almost similar as well, around the age of 18 to 19. And in those of the 2 groups, the patient to receive the surgery to treat the BPI is listed in our table here. Double abazinoplasty and pharyngeoplasty in UCLP separate individually have 6 and 5, and in the BCLP we have 3 and 3. However, in those of the group of the UCLP receiving pharyngeal flap in our list seriously, they do not receive division before orthodontic surgery. And intraoperative surgery, we do not divide the pharyngeal flap as well. And the patient complain any sleep disorder before and after the surgery, we do a questionnaire, and we call the patient back to memorize what the patient to complain yes or no. Because currently the IRB is not so easy as the 20 years ago. Not so easy to persuade all the patient or the parent to push their kids to receive a PNG in our center. So we only use the questionnaire to check the possibility of the occurrence of OSA. So in the airway measurement, we can see here, before the surgery and after the surgery, we only focus on the velopharyngeal airway, because in literature review, this one is the most important airway to relate the OSA occurrence or not. So we can easily to see here, in UCLP patient before and afterward, there is a little bit increasing of the airway volume, but it's not a significant differences. However, in BCLP, you can see before surgery is much less than the UCLP. But after the surgery, the BCLP, the airway is much similar to the post-op airway of the UCLP. And in comparison, intra-BCLP group, there is a significant increase of the peri-OGS airway increase, but in the UCLP, there's no significant differences. When we look more detail into the translational movement of the A point and B point here, in UCLP and the BCLP, for the A point advancement is around 2.9 and 2.6, means the UCLP patient, we can move a little bit forward over the point number A. They probably because of the scarring of the UCLP is much limited is much less than the BCLP. However, we could backward the B point a little bit more over the BCLP patient. Here is around 3.3 backward. However, in UCLP is around the 2.9. But all the number here is no significant differences. When we look into more detail to see within the UCLP cases, the patient with the pharyngeal flare or not, the number is 5 and 22. But the age is no differences. And between the two groups, of no cases complain about the snoring or sleep disability or sleep disorder before and after the surgery. But this is only for the questionnaire retrospective study. But in the pharyngeal flap group, they show less the airway volume than the group without the pharyngeal flap. They probably can give us some hint. The pharyngeal flap over there is really a little bit occluded of the airway. However, after Chou surgery, based on our protocol, we could provide the same similar post-operative airway for both of the groups. And we look into the translational movement into the two groups. There is no differences as well. The other side, we want to collect all the cleft patients and do the comparison between the normal patient with the class 3 malocclusion and those patients with cleft. Is any differences in between the two groups? And in our series, the class 3 patient, we have 30, and the cleft, we have 45. But to receive the Chou surgery, it shows a little bit the significant difference. That's probably all the patient with cleft is more eager want to correct their facial profile. So they underwent the OGS is in the younger age. But for the class 3 patient and the cleft patient, you can notice here in the velopharyngeal airway volume size, easily to know. For those normal patients, they could present a larger airway even before the surgery or after the surgery. And do the comparison study, of course, they show the significant difference in between the non-cleft and the cleft patient. And then we have to notice there is that over the hypopharyngeal airway, the volume is significantly reduced in the patient of the class 3 malocclusions. So this is a hypopharyngeal airway, the volume be reduced after the OGS in class 3 patients. But in cleft patients, peri-OGS, there is no airway differences. And in this, the two groups, we do a retrospective questionnaire, and we're using the stop band questionnaire instead of the PNG studies. And what is the stop band questionnaire here? Is we asking patient show snore, patient have any tire or observed, any pressure, BMI, age, and the neck size and the gender. And we have different label and the degree, severity of the stop band, the result, low, intermediate, and the high. But in our result is no difference, it's before and after the surgery. And then we compare not only between the class 3 and the cleft, and then we compare the patient in the T0 and the T1. They show no differences as well. So in the discussions, based on Professor Frank Chen's study in 2016 in scientific report, velopharyngeal airway seems the most important part to influence the airway the performance, and that could be induced the obstructive sleep apnea afterward. And compared to the oropharynx and the hypopharynx, the velopharynx is more essential. And in our study here, intra-grouply comparison, BCLP could show significant increase of velopharyngeal airway volume, but the UCLP showed a similar result. A hypothesis that probably because the BCLP patient, they accumulate more and the larger the defect, and they really received in average more reconstructive surgery than the UCLP, and those patients will show a limited airway before the OGS. However, in our protocol to show the Chou surgery, maxillary advancement, and the mandible setback after the surgery, the UCLP and the BCLP, the velopharyngeal volume, individually showed 8700 milliliter and 8900 millimeter. That means probably there's no differences here. As I already have mentioned, BCLP patient, they probably could not forward so much a point like the UCLP, but we could do our best to set back the mandible to have a better occlusal performance and a very nice facial profile. So in our group, BCLP, the B-point setback is a little bit more than the UCLP. Regarding to the VPI, because all the patients receiving pharyngeal flap in our group not divided, so all the cases we could collect is that the UCLP with the pharyngeal flap intact. However, just I have said, before the surgery, the PF group really shows less the volume compared to the non-pharyngeal flap group. But the same result, after the surgery, without dividing, they could perform the similar result of the airway volume in between with and without the pharyngeal flap. And then we try to do the research to know what the obstructive sleep apnea happened after the OGS, and instead of a PNG study. So we only using the stop band questionnaire to check, and the retrospective by the telephone calling, and want all the patient and the parents to recall their memory when they received the surgery. So this is probably a limitation for us to really and have a very objective result to identify the patient have the possibility of OSA or not, because the time is already long ago, so they could not easily to memorize them to remind at that time the problem is exists or not. So the conclusion here, UCLP and the BCLP in our scenario here, we have similar the post-OGS airway volume with and without the pharyngeal flap. When we look to compare the both group, UCLP and BCLP, after the Chou surgery, they could present a similar post-operative OGS airway volume. And if we combine all the class patients to compare the class 3 the groups, no airway compromise and the sleep disorder. So the take-home message is, I think the simulation or the protocol to deliver the Chou surgery is very important. Once your stimulation is okay and not to limit the airway design, after the surgery, all the patient could receive a nice airway volume based on this study and based on this research. And thank you for your attention.